Good evening, everyone. I'm Bernie Eliakis, CEO of CorneaGen. Thank you for participating in tonight's webinar, which is entitled CTAK, Surgical and Clinical Pearls, Expanding the Options for Keratoconus. We're pleased to offer this webinar featuring three terrific CTAK experts, Dr. David Hardten, Dr. Elizabeth Davis, and Dr. Stephen Greenstein, who together have performed well over 250 CTAK procedures. Their combined experience is incredibly impressive for a relatively new innovation in a short period of time. Today's webinar, these fine surgeons will share with you the topics of laser room protocols, day of procedure issues and items, and multiple procedure location facilitation. You can submit questions anytime during the webinar by using the questions box in the upper right hand of your corner of your screen. Please click the plus sign and it will open a text box for you to type and send comments or questions. We'll also take the time at the end of the webinar to answer any further questions posed during the session here tonight. We'll do our best to answer as many of them as possible. We want to point out that during our last CTAK webinar, which took place in November, Dr. Davis and Dr. Hardten covered the following topics: the science behind CTAK innovation approach for treating keratoconus, pre and post-op surgical pearls, and when to cross-link and the reasons why. We won't be spending much time on the topics we've already covered in the last webinar. For everyone who is tuning in tonight, in a few days you'll receive not only a link to tonight's webinar, but also to our previous CTAK webinar recording, so you have that to reference as well. And now it's time to introduce our panel of CTAK experts. First, Dr. David Hardten is a board-certified ophthalmologist and co-founder of Minnesota Eye Consultants, specializing in cornea, anterior segment, cataract, and refractive surgery. Graduating from the University of Kansas and completing his fellowship at the University of Minnesota, he has been a pioneer in private practice since 1993 and esteemed lecturer and author in the field. Welcome, Dr. Hardten. Dr. Elizabeth Davis is an ophthalmologist specializing in cornea, cataract, and refractive surgery. She completed her ophthalmology residency at Massachusetts Eye and Ear Infirmary, Harvard Medical School, and received subspecialty fellowship training in cornea and external disease, refractive surgery, and glaucoma at the Minnesota Eye Consultants. She is attending surgeon and partner in Minnesota Eye Consultants. Welcome, Dr. Davis. And last but not least, please welcome Dr. Stephen Greenstein. Dr. Greenstein is cornea, refractive, and external disease graduate from Harvard, completing his fellowship at Mass Eye and Ear. He received the Heed Ophthalmology Fellow Award and has published articles on the Cornea and Laser Institute's corneal cross-linking clinical trial for keratoconus and corneal ectasia. Welcome, Dr. Greenstein, and also very pertinent to this he is a co-inventor of this procedure we're talking about today, along with Dr. Peter Hirsch, the CTAK procedure. So without further ado, I am going to disappear here in the behind the scenes and hand this over to our fine surgeons, and we are going to start with Dr. Hardten.
Well, welcome everyone, and thank you, Bernie, for that great introduction. And I'm feel very privileged here to be speaking with these other two excellent surgeons. Here you see some disclosures, and just so that you're aware that that we have done quite a bit of work in the field of ophthalmology. So I want to talk a little bit about keratoconus, and most of this we covered in the last webinar, and so I'd encourage you to review that. But I'll just talk about some of the basics, and we can go to the next slide there. So what is CTAK? So CTAK is for the treatment of keratoconus, and keratoconus used to be a really tough disease for most patients because they would progress. They'd have to have a corneal transplant. They had long-term maintenance, and really now with the ability to alter the shape through CTAK, basically pulling back on that bulgy area of the cornea, improving the shape, and then also doing cross-linking, these patients can have a much more normal life. And the advantage of CTAK is it's customized. I know those of you that are on this webinar tonight are likely to have already been using CTAK in your practice, and so we're going to cover quite a few of the clinical pearls and surgical pearls that the three of us have maybe made a couple mistakes, so hopefully you won't in the future. We can go to that next slide there. And so, here you got that bulgy cornea. It's that bottom section in general that we're going to improve. And basically, corneal tissue addition keratoplasty. We sometimes use in our practice the name of anterior lamellar keratoplasty with regional segments, partly because that's a familiar thing to our insurance companies. But CTAK is really that customized tissue that Corneagen has provided, along with a planning process that's really changed our practice for keratoconus the last couple of years. Now, you can go to the next slide there. And when we think about the alternatives for keratoconus, again, we're trying to avoid penetrating or deep anterior lamellar keratoplasty. And we'll talk a lot about the various examples that we have in our practice. But again, we're going to focus tonight on the clinical pearls of the surgical intervention. So very video heavy. Get ready to really hone and fine tune your skills here as we go along. So I'm going to turn it over to Stephen, and Stephen's going to go through, because he's really been involved with this the longest, variety of patient selection, and then some surgical pearls. So we appreciate him being here with us all tonight.
Thank you so much, Dave. It's really, like I said, a privilege to be on here with both you and Liz. Have done so many of the early procedures, helping us really get to the point that we are today, and particularly to our East Coast docs who have stayed up a little later to be here tonight. So
you're
okay.
in present.
Yeah. Okay.
Present mode. So, there we go.
So, when we're looking for the ideal candidates for CTAK, it really is a very wide range of patients that we can say benefit from CTAK from the very beginning. We give a range of saying you want to kind of find a Kmax around 50 to 80 diopters. So really starting from mild cases to very severe cases. Generally, we want the thinnest pachymetry to be above 300 microns, although it is important, and we'll discuss this a little later in certain cases, to remember that the CTAK is sitting around the base of the cone, so it's not going to be over the thinnest point. So it's really more important to know the thickness of the cornea where you're going to place the CTAK inlay itself. Generally, the patients have a corrected vision that's worse than 20/20, so the real purpose of CTAK is to improve a patient's corrected vision. Central and paracentral cones tend to do the best because you have room to wrap the inlay around and get a good flattening. We don't really want scarring in the visual axis. For obvious reasons, the CTAK inlay is not going to improve any central scarring that you may have. So if you have especially visually significant scarring, you want to avoid those for CTAK cases. But as you'll see, and as we go through tonight's surgical pearls and videos, we really kind of pushed the boundaries of CTAK. We've violated a bunch of these principles already. And as you get more comfortable with CTAK, you will become more comfortable sort of pushing the envelope for these cases. So really diving in to the surgery itself, CTAK begins with the planning. So part of the ease of CTAK is that you can take topography images from your clinic. You will receive a surgical plan from Corneagen, and with that surgical plan, you can then place a CTAK inlay with reproducible results. So right now, the information gets sent to Corneagen. Corneagen will then give a plan to each surgeon. The surgeon does have to approve that plan, and then you do need to plan for about 6 weeks lead time to get the inlay. We're hoping that that time will get shorter as things continue to develop, but you do want to know that that lead time exists when you're planning CTAK surgery. So the plan that you're going to receive has 2 pages to it. The first page looks like this, with a recommended specs for each CTAK inlay with some alternatives that are proposed. And as I said, the really most important thing is that the surgeon is making the final selection about these parameters. So most surgeons will go with the recommended parameters initially, and like anything else, as you go through doing more and more CTAK procedures, you may start to come up with some of your own nuances and algorithms to plan for these surgeries, and these specifications can be modified. So the alternatives that we propose are really a thicker or thinner inlay, because it's the thickness of the inlay that controls a lot of the flattening. Thicker inlays are going to flatten more. And there are certain circumstances, which we'll go over tonight, where you may want a thinner inlay. You may also prefer a thicker inlay. One of the cases where a thicker inlay can be helpful is if you have a keratoconus patient who has true refractive myopia, so not just on an autorefraction, but on a manifest refraction, they are significantly myopic. I will sometimes add some thickness to the proposed inlay to get a little more refractive effect in those cases, because I want to get more flattening than just making the cornea more regular itself. The other parameter is the inner diameter. This is what's going to wrap around the base of the cone. Right now, the CTAK inlays come at either 4 or 4.5 millimeters. Most surgeons are not adjusting this parameter very much. We are working on, and CorneaGen is working on, a 5 millimeter option, so it'll give you a little bit of a wider inlay to wrap around some of the larger or wider cones. One of the reasons you might consider adjusting this parameter is if you felt that the inlay proposal is going to sit very, very close to the pupil. You could expand the inner diameter slightly from 4 to 4.5 millimeters, which will give you a little bit extra room around the pupil. But as I said, most people aren't adjusting this very much because of some of the flattening and really getting it around the cone is controlled by that inner diameter measurement. And then finally, you'll receive the plan of placement, which includes the 2 edges of the inlay, which control the CTAK length. Again, not a parameter that most people are adjusting very much along the way, but you could certainly shorten it or lengthen it if you choose. So the way the process works is you are going to upload your Pentacam scans to CorneaGen. They will load software on your Pentacam to do this. Your Pentacam does have to have an iris camera. So if it does not currently have an iris camera, it's something to just talk to CorneaGen about, or Oculus. They can either upgrade the Pentacam to have an iris camera in it, or work on some trade-in for you for one that does. But the iris camera is critical for identifying the pupil location. We're also working on integrating the Galilei from Zemer to be able to upload measurements from that device as well, with some other devices hopefully integrating down the road. In terms of femto lasers, most femtosecond lasers will work to do CTAK. Essentially, if the laser can create a channel, it can probably do CTAK. The Zemer series of lasers, the Z4, Z6, Z8, all do CTAK inlays. Johnson & Johnson, Zeiss, Alcon all do as well. The Johnson & Johnson IFS will make an inlay because it can create a channel, but the Catalyst will not. Alcon's LensX or FS200 will both do so. And then there is also an instrument set that is available through Corsa. Some of the important instruments are particularly the marking instruments. So the markers are designed in 1/4 millimeter steps. There really aren't any calipers that are designed with that kind of measurement precision. So that is very important for marking, which we'll go over in just a minute. The dissectors are very important because you really need clean dissection of the channels to be able to place CTAK inlays. Unlike a synthetic inlay or a synthetic segment, where the segment itself will dissect the remaining adhesions, the CTAK inlay, because it is corneal tissue, is not going to be able to do that. There's an insertion of forceps which we designed, which allows you to grasp the CTAK inlay firmly, but also guide it around some of the channel when you place it in. And then a manipulator instrument to both push and pull the inlay, with finally the ability to smooth it at the end. So very, very quickly, and then we're going to dive into this in much more detail. When you do CTAK, you have to mark the segment edges with the center of the pupil, then generally mark inferiorly and temporally. Use an optical zone marker to encompass those marks. The femtosecond laser will make the channel, dissect the channel, place the inlay, and smooth the inlay into position. So going through each of these steps, the marking is very critical for CTAK, because when you are using your femto laser and you're trying to find the location to create the channel, the mark is what is going to guide your laser to create that channel. We're used to using the pupil as our guide with the femto laser. When we do LASIK, when we do most other procedures, we're trying to center everything around the pupil. But in CTAK, we are trying to center everything around our marks. So in the plan, you're going to be given a temporal mark, inferior temporal, and inferior mark. I think most people, including myself, really only mark at this point either inferiorly or temporally, or just the infratemporal alone. I prefer to mark both temporally and inferiorly. So what I'll do is I'll mark the edges at the slit lamp sitting up. I'll mark the center of the pupil with a Sinskey hook sitting up at the slit lamp. And then when the patient goes and lies down, I will do the rest of the marking. Now you'll notice in the plan you get a very, very detailed mark. So this is 2.08 millimeters. There is nothing that can mark to that detail. So you do have to pick the 1/4 millimeter step that is closest, and I would generally err on the side of being more peripheral than central. So at 2.08, I think the best way to handle it is you mark 2 1/4, and then you know that with your femto laser, if you have to decide 1 click in or 1 click out, you're going to go 1 click in that case. But you always want to err on the side of being a little more peripheral than central to get the best effect. So this is already marked at the slit lamp. We're going to make the inferior mark. We're going to make the temporal mark based on the central mark with the Sinskey hook. And then we take the optical zone marker, which is either going to be 4 or 4.5 millimeters. We encompass those two marks. And then now when we go to the femto laser, what we're doing is aligning the channel with our violet mark. So we kind of ignore the pupil at this point. We trust the mark. And we then align the femto laser with that channel, creating the channel around it. In this case, I'm using the Z8 laser. One of the unique features is that it can create a defined channel to the length of the CTAK inlay with 2 incisions, 1 on each side for both pushing and pulling the segment. But you can absolutely do this, and I've done it many times with a laser that creates a 360-degree channel, and you'll be able to place these segments very, very well. So here's the procedure itself. We've already now created the channel with the laser. So we're going to use a LASIK dissector to open the incision. You want to do this gently, but you really do want to get a good dissection. These are only 200 microns deep. So unlike a Intax where you have to kind of dive down, these really open more like a LASIK flap. Again, you want to get very good dissection. So you'll see that I'm aggressively dissecting back and forth to really make sure that the channel is open. These dissectors do leave a very wide opening, so you have a very good view of the channel as you're doing this. You can really see yourself getting that dissection, making sure that you're breaking all the adhesions. You want to do a little bit more dissection rather than less to make sure. Then you do want to dry the inlay. So it's easier to place the inlay dry. So I dry the front of the CTAK inlay. These do not need to be dehydrated. So because of the gamma radiation, they have a little bit of firmness to it. Then you open the incision and you place it in. Now you want to hand over hand the instruments when you pull out the CTAK forceps, because sometimes if you just try to pull out the CTAK forceps without supporting it a little bit from behind, you're going to pull out the inlay with it and kind of go back and forth. So if you give it a little support, you're going to be able to push it in, bring your CTAK forceps out, and then you can glide the inlay along within the channel. Try to get it as far as you can around the turn, and once you can grip it, you can then take the manipulator and bring it around the rest of the way, finally smoothing it out and getting it into position. So this is a pretty long inlay. This inlay was about 330 degrees, but we were able to place it in with one inlay pretty easily. Now, as I said before, dissection really is key. You do need to have a very complete dissection. So here you can see I'm kind of struggling. I can't really get the inlay in. I'm trying to push it. And I realize that I have an adhesion still that the inlay won't go through. So if you can see in slow motion here, you can finally see where that adhesion breaks right there. And that's the reason that I can't place the CTAK inlay. So once I've identified that the adhesion is broken, I now already see that the CTAK has passed that mark, and I can kind of smooth it out as we go along the way. So do have to use a little bit of force to kind of get it around the edges, but it's now moving just fine and it smooths out easily. With CTAK, you don't have to push the inlay all the way to the final edge. You really have to get it around the final turn. And generally with the applinator, you can smooth the inlay out the rest of the way. So with a clean dissection, if you're having trouble pushing the inlay in, just double check that you don't have any adhesions, and then usually it will go in very smoothly. Now we just went over in the first case putting in a long inlay. So some of these inlays are 300 degrees and even 330 degrees. So they're pretty long inlays that you need to put in. In the first case that I showed went very smooth. It was pretty easy to place. This case was not quite as smooth, went in very easily. I was able to kind of feed the inlay all the way through. I kind of smooth it out as I move along. And again, now I've gotten around the turn. I think I'm doing pretty well. So I keep smoothing, not really moving. Then I try to push it a little more. It is moving a little bit, so I don't think that there's an adhesion there. But I'm not really getting it to kind of smooth out. It's kind of folded on itself a little bit. Take the manipulator. I still can't really reach, so I try to push it around a little more. And then I decide I'm going to try to smooth it out more because I think there's like a little bit of fold in there that I could just grip a little better. Push it a little more. Then come back around the other way. Finally, I feel like after smoothing it, I can now reach it a little bit better. Finally do get a grasp of the tissue, although not particularly easily. It finally does kind of unfold, and now I've kind of moved it around, and now I still have to spend some time bringing it over to the final edge. So I'm getting it slowly but surely. Have the patient look down, keep bringing it over more and more. Finally, I feel like I have gotten it to the edge, bring the other edge, unfold, and I am done. So after a little bit of heartache and now the final smoothing, this inlay worked just fine. It's a 330-degree inlay. It's in position. It went in all at once. But clearly, a lot of manipulation involved, more than you might want to do, especially on your early cases. So there's a pretty easy solution for this, which is you can just use a Westcott scissors and cut the inlay into two and put them in as two smaller segments. So in this case, this patient did have some corneal scarring. I was a little concerned trying to be very aggressive, very close to the scar about maybe tearing the channel. So I really didn't want to do a lot of manipulation right around the scar area. So I divided the inlay into two. I placed one segment in, and then again with that hand over hand to support it, you place the next segment into place and keep moving it into position just till it gets close to the inlay that you've already placed. You can then smooth it out into position, and now you have a 330-degree inlay that looks just the same as the other one, but cut into two segments. So I think this is a really nice way of dealing with long inlays as you're getting used to the instruments. If you're having a struggle kind of bringing the inlay all the way around, there's no harm in making it two separate segments, putting them in from either direction, and having them meet in the middle. The topography change, all the results that we've seen when you do this are pretty much exactly, they're not pretty much, they are exactly the same as if you put them in as one single inlay. So I just mentioned that patient had some corneal scarring that we were navigating around. So this is one of the principles that we started with at the beginning, which is that we generally don't recommend doing CTAK in cases where you have visually scarring in the visual axis. I would refine that statement to saying that we really don't recommend CTAK when you have visually significant scarring in the visual axis. So one of the easiest ways, which we're very used to doing for a lot of the ways that we kind of check visual potential in these corneas, is an RGP overrefraction. So if a patient is generally seeing well in an RGP or a scleral lens, even though they might have scarring in their visual axis, it's a pretty good indicator that they're probably going to do pretty well with a CTAK inlay. So here's a case of a 26-year-old male. He was actually a PhD student who was wearing scleral lenses and did get good vision in the scleral lens. He was getting vision to about 20/30, But you can see that his uncorrected vision and his spectacle correction really isn't very functional. So for him, his biggest issues were that he was wearing the scleral lens, but after about 8 to 10 hours, he really had to take the scleral lenses out. He felt that he couldn't wear them longer than that, but with his PhD studies, he was really fighting keeping them in 14, even 16 hours a day on the lenses, which was already tough at this stage and only was going to get tougher as the years went on. So these tend to be really good cases for CTAK because even if you can give a patient the ability to wear glasses and have some more functional uncorrected and corrected vision and just be able to limit their contact lens wear so they can feel more functional, it is really a place where CTAK works very, very well in some of these more severe cases. Just on the side, when it comes to contact lens fitting over these CTAK inlays, unlike previous experience with Intacs segments where it can actually make fitting scleral lenses and rigid lenses somewhat more complicated because the lenses will frequently rub against the Intacs, because the contour of the peripheral cornea remains the same with CTAK, we don't really see any of those difficulties fitting scleral lenses after the CTAK is done. And you can see in this case, we placed the CTAK inlay, a long inlay. We got just over about 20 diopters of very central flattening. This is a patient who clearly surgically would really only benefit from a DALK or a PK at this point. And their scleral lens vision remained the same. It was 20/30, but their corrected vision improved to 20/50 and their uncorrected vision to 20/80, much more functional when they don't wear their lens. So even in these cases of scarring, a CTAK can be beneficial. This was an interesting case that I recently encountered with CTAK. This was a 25-year-old who really had nothing much of note. They seemed like a perfect CTAK candidate. They had kind of a mild, early moderate keratoconus, not great glasses vision, but not terrible. And they just wanted some improvement with their vision. And so I offered them to do CTAK. And you can see I placed the CTAK inlay, and 1 month later, his vision really was not just it wasn't better, it was actually slightly worse. His uncorrected vision was 2100, corrected vision 2040. The patient just really didn't notice any improvement. He didn't notice that it was particularly worse, but he kind of said he didn't think the CTAK did very much. When I looked at the difference map, you could see that in this case, I was getting more nasal flattening than I would have expected. So I had really taken the flatter area nasally around the 150 mark, and I flattened it even slightly more. So I decided to take him back and do an adjustment of the CTAK inlay, and I decided to shorten it. So I wanted to really just have that temporal flattening without the nasal flattening. So I went back in through the incision. Now it is important to re-dissect these inlays. They are very adherent to the channels and to the stroma once you do it. So I'll put a little BSS in the channel to separate the inlay from the corneal stroma. I do dissect both above and below, and then it is pretty easy once you can break make that separation to bring the inlay out. And you can see that I've already marked nasally where I kind of want the inlay to end up. So I bring it out past that mark. I take a Westcott and I slice off that area of the inlay, and then I bring it back into position so that I have shortened the inlay just a little bit and really created only a temporal effect with the flattening now. So that's really a nice thing about these inlays, which is that unlike a synthetic segment where you kind of get what you get once you put it in, and we have all had experience placing those kind of segments and being underwhelmed or sort of being unpredictable with the results that we get. With CTAK, you actually have the added benefit of being able to potentially adjust those inlays as needed in certain cases. And now you can see that once I made that adjustment, I'm getting really a very nice temporal flattening, infratemporal, but really all the way up to the to temporally, where this is now a much more regular cornea, and the vision shows it. So his uncorrected vision now improved to 20/50, and his spectacle correction is now 20/20. So this adjustment where I've now flattened temporally and gone back to its natural steepening nasally was very, very helpful and relatively straightforward to do. So we've gotten a lot of questions about placing CTAK after Intacs. And I've done now multiple cases where I've removed Intacs that patients didn't feel worked as well as they had hoped, and then placed a CTAK inlay in its place. And it works very, very well. The key with doing this is really incision planning. So if you look at the picture on the right, that blue mark there is where the old original Intacs incision remains and the scarring from that incision. Now, normally when I remove Intac segments, I make a new incision pretty much as close as I can to the Intac segment just to make my life easier. So once you do that, you really just need to do a limited dissection above and below the Intac segment, just enough to pretty much get your Sinskey hook through the opening of the segment, and usually you can then bring the segment out with a little bit of force. But in these cases, you're not going to be able to thread the CTAK inlay through these scarred incisions. So wherever you make this incision to remove the Intac segment is going to limit where you can place the CTAK inlay. So the first rule, if you're going to place CTAK segments after Intac's removal, is it's important to send the data to Corneogen from your Pentacam before you ever remove the Intacs. Even though there might be some changes in the CTAK plan, some changes in the thicknesses that are recommended because the cornea is likely going to steepen and change somewhat in curvature when you remove the Intac segment, it will give you a rough idea of about how long the CTAK inlay is going to be and around where you want to be placing your incision. So in this case, you might want to really make sure to keep your incision close to the original incision, even though there is going to be more dissection. It is going to be a little more heartache to get the Intac segment out, but it is going to leave you more room to then place your CTAK inlay when the time comes and really get the CTAK effect. So this is the actual case of the plan to the left. And you can see here, I worked nasally because I really didn't want to limit the temporal placement of the CTAK inlay. So there was an original Intac incision that was made nasally. My next incision was right next to that one to remove the Intac segment. And now this actually left me enough room to make the incision that's recommended to place the inlay. And I still actually had room with the Zemer laser to create another incision inside of that and be able to still work very naturally, both pushing and pulling the inlay into position. I've also done this with the ability to create a 360-degree channel, so you don't have to create just this channel in the area of the CTAK inlay. But even if you create the 360-degree channel, you can't really bring the CTAK inlay through all those incisions. So it still works very well, and I've done it, but you still have to be mindful of where you're going to place your incisions so that you can place the CTAK inlay into position when the time comes. So here's a case that was actually sent to me with Intac's removal for potential CTAK, and this patient had an initial the initial Intac incision, which was placed temporally. And then there were two incisions that were placed right next to the superior and inferior Intac segment temporally to remove the segments. And if this were my own case and CTAK wasn't a part of it, I would have done the exact same thing. That's the easiest way to remove them, and the easiest access is temporally to do it. So it makes sense to remove them this way. But you can see that if you have the CTAK plan beforehand, and you want to place a CTAK inlay in this case, it's going to be really difficult now with these incisions because you can try to cut the inlay into two pieces, but you're really going to be left with a pretty substantial gap, which is and the gap is going to be temporal, which is likely going to affect your ability to get really a good result. And in this case, I actually felt that there was too many incisions here to be able to get a predictable result with CTAK. And I actually offered this patient topo-guided PRK, who fortunately did well. If you have the plan beforehand, you would then see that you could make your best bet is to make your incision nasally, either one incision and work both ways, or you could even make two incisions right against the intact segments nasally, because you have a lot of gap there, and you'd still be able to place your CTAK inlay. And in this case, you could cut the inlay into two different segments and just place them as close as you could to that old incision scarring and get a good effect. So you can definitely do these cases. They just need a little bit more planning. And the real key is sending your data with the intact segment in place for proper incision planning. So these were the first few cases that I had done where I removed an intact segment, placed a CTAK inlay. And you can really see the effect of CTAK, especially on corrected vision. So these patients did much, much better with their CTAK inlays compared to the intact segment. So there's a lot of benefit to doing it. These patients were very, very happy with the CTAK result, just a little bit more planning involved. The last case I'm going to go through are with ectasia after LASIK. So again, CTAK can be done in these cases, but not probably the first cases that you want to be doing CTAK in. With LASIK cases, you have the LASIK flap that you need to navigate. Plus, these corneas generally are pretty thin. You're dealing with corneas that already were excimered, usually with a myopic correction, and now they've thinned further from their ectasia. Plus, you have a LASIK flap that you have to navigate around. So there is more that you are working on to really make sure that you get these inlays in proper position. OCT can be very, very helpful in these cases to try to identify the depth of previous LASIK flaps, where you have depths now with femto flaps that are generally somewhere maybe between 100 and 120 microns. But it's really important to identify those older flaps, which were microkeratome flaps, in this case, almost 200 microns deep. And in this case, it's going to be very difficult to place a CTAK inlay with that deep of a flap and not get in the flap interface. Certainly, you cannot place the depth of that channel at 200 microns depth. You will be in the flap interface when you place the CTAK. So this was a case where I was planning to do a CTAK in a LASIK, an ectasia after LASIK. And this is where it is important to remember that you're placing the CTAK inlay around the thinnest point. You're not placing it over the thinnest point. So you do have a little bit more room to work. This patient had about an 120 micron flap and probably about 450 microns where the inlay is going to be placed. So there is enough room to do it, but we are going to do it at a deeper depth. Now, a nice thing is if you have a built-in OCT into the laser, again, this is with the Zemer laser that I use, and then you can actually double check your depth before making the cut. So with the built-in OCT, you can both see, are you deep enough below the LASIK flap and also not too posterior in a very thin cornea to ensure that you're getting the cut that you desire. But again, with some of these principles, you can use lasers, which most femtos don't have that built-in OCT, to still do cases of ectasia after LASIK. So some recommendations is I would not start with these cases. I would really get used to using the instruments beforehand. You really do want to place these deeper, so at least 250 microns deep. I'm really going maybe 275 on most of these cases. I think Dr. Hardten will tell you and Dr. Davies that they go even deeper than that, which I think is totally reasonable. This is a case where unlike using a thicker inlay, you really can go thinner than what the recommended inlay specifications are, because I find that there's a lot of biomechanical weakness in these corneas. So when you place these inlays, you really do get a substantial amount of flattening. In a lot of these cases, I've gone 100 microns thinner than recommended and still gotten a lot of flattening in these corneas. And that actually gives you more room to work. Working in these cases with a little bit of a thinner inlay is actually easier than a thicker one. So I would recommend actually going thinner in these cases. I would always go about 50 microns thinner and many times even 100 microns thinner. And the real key when you're doing this is you really have to just make sure you're identifying your surgical planes as you're doing your dissection. So here's a case where I was doing a dissection of a channel. I'm moving I'm dissecting. I think things are going pretty well. And then I'm clearly now see that I'm kind of moving into the zone, and I'm kind of concerned that I've now entered the LASIK flap, not the channel. And you can see I'm definitely moving pretty centrally, and I am definitely in the LASIK flap interface, not the channel. So I go out, I go back in, I really try to now push down posteriorly, make sure I'm in the channel. You can see I clearly was in the wrong place because I have a pop there as I'm going in. I know I'm now in the channel. And you just want to do everything a little slower here. You want to really make sure you're in the channel, but you can see how much force I can put on that channel once I'm in it. So once you know you're in the channel, the dissection should be pretty clean. And again, placing the inlay is exactly the same. You have to really go posterior, make sure you're in the right plane. I have placed this in the interface even after I dissected the correct plane. And that did require taking it out, putting it into the right plane, and actually suturing a little bit of the LASIK flap. So again, you really want to make sure you're in that right and correct plane. But once you are, then the case is the same. So once you have the inlay in the proper channel, you can push it, you can pull it into position. It should glide into position just the same. And then you can smooth it out and the case is done. So you can do these cases in ectasia after LASIK, but like intacts, there's just a little more planning involved. You have to make sure you have enough thickness in the area to place it. You do want to go a little bit thinner on the inlays and just be a little gentler and slower with the surgery to make sure that you're in the right plane at all times. So with that, I'm going to pass it on to Dr. Days to take over for some more surgical pearls from her experience as well.
Great. Well, that was very informative, Steve. So I really appreciate it. I learned quite a bit from that, particularly the in-text removal and then post LASIK cases. And I know you and I had a conversation, and you said you like to wait about a month after removing the intact segment before moving on to CTAK.
Yeah, I think you do want to give the cornea a chance to settle down a little bit and just see how steep it's going to get once you remove the intacts, just to get a decent topography to be able to map out and get kind of the proper thickness of the cornea. I haven't found waiting any longer than that really makes much of a difference. So that seems to be the sweet spot to let the cornea recover and then get good topography measurements to move forward.
Great. Great. Thank you very much. So I'm just going to talk about, obviously, I'm not as experienced as Steve by any measure. So I'm going to talk about some little pearls I learned along the way. First of all, and for those of you who have started out doing it, you'll learn that, first of all, these segments are quite slippery. So drying them does help, but even in that case, they can still be slippery, particularly when you try to grasp them with forceps. So I've tried a variety of instruments to hold on, to be able to have some force to push it through the channel, obviously not tearing the channel. And so some of the instruments I've tried, one of the instruments I've tried where there's toothed MST forceps. And this particular one has a downward curve. It's not so helpful as having a curve to the right or to the left, but it is toothed. And so that helps to grab the segment. So let's see. So here, and the other thing to do is make certain that you grasp at the very tip of the segment, because if you grasp too far back, at least on the initial grasp, the segment that's anterior to that can fold over backward. And as Steve was talking about, using this hand over hand approach, as you push it in, sometimes then re-grasping right behind it, so that it doesn't come back out, which it can at times, really is helpful. And then I find that always wetting the surface before using this. This is called an applinator. I call it to my text the milker, because it kind of helps milk the segment around, because it does get all bunched up. What I like to do is have the plan that CorneaGen sends taped up next to me in a surgeon's view, so inverted, so I can see how far around I should expect this segment to go, because it really can wrinkle up, and you can be deceived by thinking you've flattened it all the way out when you haven't. And you can really press down, and that's why it's called an applinator. It's not just pushing it around, but you want to press down at the proximal end of the segment into the tissue to milk it around. And you'll see that in some of my next videos. So those forceps are okay for for short segments. But I found them not to be quite as ideal for long segments, at least. Can we go back to the previous video? I don't know why it advanced on its own there. I'm not quite certain why it's just advancing through. There we go. Okay, so it's advancing through the slides somehow without me touching the screen. Okay, so here's a long segment. And so I use the IFS laser, so it only makes one cut. So not like Steve's laser where he can make a couple cuts. So I have to push it through one direction. And I use the whole segment rather than cutting it in half, although I do like that approach. So I'm pushing it through from one side. I'm going to try to get it more than halfway around, so that then I can go in the other direction and then pull it through with these forceps. But again, what you need to do is periodically milk it around so you can see it start to extend. And I'll, for the sake of time, somehow the videos are jumping forward when if you can go back to, maybe I'll let you control it, because every time I touch the screen, it advances to the next. And then, so here I'm reaching through around the other side and grabbing it to pull it through. But what you can see is because it's curved in a vertical way rather than a horizontal way, I've kind of dissected centrally, which turns out to be okay in the end. But that's why in this particular scenario, I don't think this instrument, or at least the way in which I'm using it, is ideal. So what I do, once I get it into position, I then take the applinator and just make certain that the tissue is pushed back up against the channel superiorly, so it's not impinging on the pupillary axis. So I'm first just making certain it's all smoothed out, but then right there, I'm pulling it back away from the pupil. And this was about a 330-degree segment. The other thing you want to do is you don't want your segments to underlie your incision. So you want them probably 15 to 20 degrees away from your incision so they don't erode up and through your incision. And unlike at least in Intacs, when I used to do those, I would put a suture in. Don't need to put a suture here. You can go to the next slide. And then this is just re-emphasis on smoothing out the wrinkles. This particular piece of tissue was a little bit more edematous or had more of an opaque coloring. So you can really see when it gets bunched up and has these wrinkles. And again, really important to smooth those wrinkles out. Um, if they're left in place, you can see them at the slit lamp afterward, but also to make certain that the segment is going the full extent. So there you can see quite well a whole bunch of wrinkles bunched up of the tissue. And so making certain that you push it as far around as possible, and it really can extend, and making reference to the plan so that you know what it's supposed to look like. And then you can go to the next slide. So one thing, and maybe just pause it for a second. I know there have been some questions about, just in, for example, when we do LASIK and make a LASIK flap, what happens if you say lose suction or there's an abnormality? This is a case, I didn't lose suction, but suffice it to say, I had a new technician. I had done a check on the entries. I always check what the tech has entered into the laser for the plan. But I was only doing this patient's left eye, and I didn't realize that she had entered in the IFS checked off OU. So then when we brought the patient into the room, it defaults to starting with the right eye. And then if nothing's entered in for the right eye, it'll be a default setting, which is about a 1 millimeter channel in the periphery and a 90-degree cut. So rather than I wanted a 63-degree cut. So I put the suction ring on, immediately saw, stepped on the pedal, immediately saw that it was a very peripheral 1 millimeter channel and it made a 90-degree cut. So in this case, I simply reapplied, making certain we had the correct entry, reapplied suction and cut the correct channel. Fortunately, and this kind of is similar to what Steve was talking about, because I wanted to enter through 63 degrees, and that was not going to be crossing over the 90 degrees. That was possible to do in this situation. But, in answering the question, you can go ahead and proceed with this. In answering the question of whether or not, if you lose suction, whether you can just go ahead and attempt again. In most cases, that is something you can do. And this was a rather thick segment and kind of a tight channel, but it went in perfectly fine. And obviously, most of you who have done these know that typically we do them in the OR, except in rare scenarios where we will do the whole procedure in the laser room. It can get into billing issues with the tissue by placing it in the laser room. And one of the things that comes up with some surgeons, because they might have a laser in one location, OR in a different location, and cross-linking availability in another location. The question is, how can you coordinate all this? We're fortunate in our practice that we have everything all in one location. So we move from the laser suite right over to the OR, insert the segment, and then they come back out to clinic and have cross-linking that day, or can come back on another day and have cross-linking. But there are surgeons who that's not possible. and you can do your intralase cut in a laser in a different facility on a different day, and then come into the OR and then re-dissect open the channel, insert your segment, and then do your cross-linking on another day. In our last, Dr. Hardten and I's last discussion, last webinar, we talked about timing of doing cross-linking. There isn't obviously for CTAK any specific data on the ideal timing, but looking at the healing process and the maturation of cross-linking, as well as looking at some data from Intacs, you probably have up to about 3 months after CTAK to do cross-linking, in which it would be beneficial. So there isn't a rush to immediately do it. Obviously, it's more convenient for the patient, but for those of you who have this instrumentation in different locations, it's all still possible. It just requires some coordination and planning. So I think we can go to I think the next is, and so now Dr. Hardten will take it from here on his surgical pearls.
All right. Well, excellent information so far. And so if you don't mind staying up a little bit, I'm going to show you my typical case. It's very important to center and mark properly with the docking. And like Stephen mentioned earlier, you'll want to watch for parallax with the laser. So you want to mark the apex of the cornea, and that helps you to, when you're docked underneath the laser, to make sure that, because the pupil is not necessarily reflective once you've docked. The other thing is I do prefer most of the time just to do one mark infratemporally and then the ring or the circle marking. And but in complex cases where I feel like I'm really far inferiorly decentered, most common, then I may make 3 or 4 marks to try to help me again when it's docked onto the laser. And then, like we mentioned earlier, I do prefer a little bit deeper for post LASIK. If you have a very shallow flap, going 250 is probably okay. But in general, I'll do 300 unless I know that that initial flap was pretty thin. And then I tend to prefer to over place my inlay, and then I'll smooth, because that way, if it's about 30 degrees away from the incision before you smooth, then you're going to stretch it back over towards the incision to get it, kind of like Liz said, about 15 degrees away from the incision. And that allows it to seal down without having to place sutures like we used to with Intacs. And so that provides a nice smooth ability to get the smoothing effect to pull it back towards the incision. The surface by this time is usually pretty dry, so I start smoothing with a BSS cannula that's on a big 19 gauge, like the one they use to squirt for cataract surgery, and then move to the little milker or the roller, like Liz had said. So we can go to that next slide there for me, Emily. So we're going to talk a little bit about some of the challenging cases, decentered docking, tearing of the channel, tight incisions, and wrinkles. And so I just have a few cases here that I don't think will take too long. This is one where a very thick segment and it was a 4.5 millimeter zone, so they're a little bit tighter. And so one of the things to do is to use 2 hands to grab a hold of the inlay, and kind of like Liz said, it's helpful to have it slightly dry but not super dry. And here you see that it's a little bit slippery, and if you can get one of the points of that incision into, or the points of the CTAK into the incision, grab it with the second instrument, and then basically do a hand over hand, to then kind of shove it into that. And this happens in narrow and then also in fairly thick segments. And then I'll use the dissector or the channel advancer to go ahead and advance it. You have to be very careful to follow the curve of your channel, because if you try to use that in too straight of a manner, then what's going to happen is that you can potentially tear the channel. And I'll show you one where I tore it and how I managed it. But that hand over hand method is very helpful in the tighter incisions. You can go ahead and go to the next slide for me now. So this is one where I think the technician had thought, oh, the tissue being dry is what we want. And it was sitting out while I usually have the technician in the operating room find the tissue and then put it on a Maricel or a Wexcel while we're doing the laser cut, because it takes a few minutes for them to find it. Well, here it ended up being very dry, so it was very, very sticky. And so I think you want to have it dry, but you don't need to make it desiccated, and because they are, like Stephen mentioned earlier, they're already fairly stiff. And so this is one where I probably just should have rehydrated it, because the tissue, I think, was too dry, and then it became a challenge with it sticking, folding, and just made it harder than it really should have had to be for me. And again, I end up being successful, but if you have it too dry or too wet, you can't grab a hold of it, or it's going to stick in the incision too much. So you can go to the next slide. So here's the one where, again, this is a fairly long channel, and so you want to be very careful with the channel edges. So here I'm inserting the tissue. You can see it folds a little bit in that situation there. So I'm going to use the advancement tool, and you can see how far I'm going into the channel. And then what's going to happen is that I'm paying attention to the front end and not necessarily to the back end. And so as I'm advancing the tissue, at some point here, we'll show you that I actually tear the tissue. So you need to be very careful as you're going around. So there you can see that I've kind of torn that outer component of the channel, and I don't think I recognize much of this yet. And then here I'm going to go grab it, and I'm going to tear the other direction a little bit. So you just have to be real careful at those channel edges. And so here I'm grabbing it, pulling it back the other direction. And so again, you can see that I've ripped that channel top open a little bit. Now, potentially, if you felt super compelled that you keep that whole piece of tissue, you could probably suture down the channel. What I ended up doing is I felt like if I sacrificed 20, 30 degrees of the CTAK segment, that I'd still be okay. And so I basically then trimmed that segment and then just had the channel areas where the channel was intact is where I had the tissue and where I placed it. So you just want to be very careful when you're going with an instrument that doesn't necessarily follow exactly the curve of your CTAK channel. You want to be careful not to tear that front edge. And then here, like I said, I decided to sacrifice a small portion of the tissue. You can go to the next slide now, there, Emily, for me. So the thin tissue has a little tendency to wrinkle as you're inserting it, and then this piece of tissue is probably also a little bit drier than ideal. So what you'll see is that in kind of that midsection, it'll wrinkle, and the best way to get the wrinkles out is to avoid it when you're pushing in the tissue. But then if it's wrinkled in the middle of the segment, what you can oftentimes do is just massage out that wrinkle and then basically allow it not to be doubled down. And then if it's remains wrinkled, then you can pull the tissue back out again, reinsert it, or grab it from the other side. So here I'm massaging on the top, to try to improve those wrinkles. And you definitely don't want to leave one wrinkled up. And it's clear enough, it's sometimes a little bit challenging to be able to tell and see. But here you see I go back in underneath to stretch out that wrinkle. I decide I need to pull it back out again, straighten it out before I advance it more. So you can see there's still that fold on the left-hand side of your screen. And now I've got the wrinkle out. I'll go back and advance the tissue again without the wrinkle in place. So you want to really make sure that you don't have it wrinkled up, and the smoother is really, really helpful with that. But sometimes you'll need to go in, reach, grab the tissue, and you can pull it back and forth. So here again, I kind of massage out that last couple little bits of wrinkling. You can go to the next slide now for me too. So I'll kind of take us through a little bit of the summary here. CTAK has been an amazing addition to our options for keratoconus management. As you saw, with careful planning and good surgical technique, we can get improvements in both uncorrected, best corrected vision, and most importantly, these patients are still able to wear a scleral contact lens. And then, in our younger patients that are having CTAK, I think that the progression of keratoconus, the ability to stop that progression with cross-linking is really, really important. We've talked about a variety of different things like avoiding wrinkles, care in the post-LASIK patients, watching the wound edges. You heard a lot of good pearls on post-LASIK patients, removal of intacts and post-intacts, kind of upgrading to 2025 technology. And so I'm hopeful that this helps all of you in your surgical techniques. And so I think that we're at a point now where we could probably take some questions. And I don't know if it's Bernie. I think you're going to help take us through the Q&A, and please review the other video. If you are new to CTAK, review that initial video, especially. This one's kind of more the advanced version that after you've done 10, 15 cases, you'll be glad to review again. But we're happy to answer any questions and look forward also to seeing you at the ASCRS meeting.
Excellent. Thank you so much, you three, for a great informative presentations here and with the videos and everything. As Dr. Hardten said, if you have any questions, please submit them by clicking on the question box on your top right and type in your question. So there is a question here submitted, and it is around cross-linking. What is the preferred order, CTAK then cross-linking, or vice versa? And we could probably just give that around to all of you on that one. Maybe we'll start with Dr. Greenstein.
So I would say we generally do them together just for convenience for the patient. We do also have the equipment all in one facility, so we do that for convenience. I do think that for certain billing reasons and also just where things are, you have to potentially separate it. I don't actually think it matters that much. I think you could do it either way. I think the best thing to do is to put the CTAK in first and do cross-linking after. I think that makes the most sense. You're going to cross-link the tissue a little bit, but also cross-linking really is designed to stiffen the cone itself. So you really just need to get that good cross-linking effect inside the CTAK inlay, which I think works very, very well. So there's a little concern people have that the cross-linking is going to affect the topography, and then that might affect the CTAK plan. I would say that would only be the case in extremely mild and extremely young patients, because in those very mild cases and those younger patients where we do see sometimes a lot more flattening with cross-linking, that might be the case. But for most of your regular moderate keratoconus, more severe cases where you're going to get a diopter to a flattening, it's not going to affect your CTAK plan at all.
The only other point I'll make is that we do see quite a few people that had cross-linking a year ago, 2 years ago at an outside facility, and they're still struggling with, and it's mostly spectacle time. So Stephen made the point of the graduate student that just really needed less time in their contact lenses. And so that maybe they can still wear a scleral lens, but if they could have another 2 hours in the morning and 2 hours in the evening of being able to have reasonable vision with spectacles, then now they come to us, and the CTAK is an excellent option for that patient to improve the shape, improve the uncorrected vision, so they can have a little bit more time in spectacle correction rather than a contact lens. So in those patients, depending upon what the time frame has been and whether they have had some progression, we'll oftentimes cross-link them again because we're already, giving them a lot of anesthetic, doing something surgically. But if they haven't had any progression at all, but they're just concerned about their topography, then we'll just place the CTAK inlay at that point.
Dr. Davis, anything to add on the cross-linking or the order of the procedure?
Yeah, I mean, it wasn't certain if the question was asking, that you're going to be, like Dave said, the cross-linking was done a year ago. Maybe you'd get slightly less effect. You're still going to get a big effect with CTAK, but it might dampen it slightly. But around the time, of doing them all, I think you could do them in any order. I have done CTAK, and then for scheduling purposes done cross-linking a day or a couple days later. And what I can tell you is that just doing CTAK alone is very easy for the patient, comfortable. The next day, they don't have any discomfort post-operatively whatsoever. Not so with the cross-linking. So if you want to get them to come, if you're going to space it out, you want to get them to come back, I think I'd rather do the CTAK and then the cross-linking, because if you do it the other way around, they might not come back for the CTAK if they think it's going to be, as miserable as the cross-linking.
I would say one other thing about doing the cross-linking either simultaneously after CTAK or even a day or a few months later. I don't really clear much epithelium. I don't know what either of you do above the CTAK inlay. I don't think that you have to really cross-link that area significantly. So, and I actually think the CTAK demarcates the cone area very well because it should be inside of it. So I really only clear epithelium if I'm doing cross-linking inside the inlay. I don't know if either of you do it differently, but that's generally my technique.
Yeah,
Yeah,
mostly just center.
now I take off whatever seems to be very loose and make sure there's a small epithelial defect, because I think it's mostly when it soaks in, it moves out to the other areas, and we don't actually add riboflavin during the portion of the cross-linking, because if you do, then you've got epithelium and the layer of the riboflavin that's blocking the ultraviolet light. So I think even with a small epithelial defect, you get a pretty reasonable soaking effect with the riboflavin. And so I agree, like you said, it's I had one guy today that his whole epithelium was super loose, and what I don't like is edges, because they don't oftentimes heal very well. So I just buffed off those edges, but that he had basement membrane dystrophy and loose stuff almost all the way out to his limbus. So I kind of clear whatever is loose to help it heal better. But you're right. I don't specifically try to take a lot off over the inlay.
One more question. Speaking of other procedures, what experience have you all had, or have you even done any refractive procedures after CTAK or after CTAK and cross-linking, or your general thoughts on that to perfect vision even more?
So I did, Tuesday, or I guess it was just yesterday, I did cataract surgery in a patient. This is the second cataract surgery I've done in a patient that had CTAK, and I've done quite a bit of cataract surgery in intact patients. It's really hard to see the anterior capsulorhexis, and so I do trypan staining on all my intact patients. Much easier to see through the CTAK inlay to do the cataract surgery. And so in those patients, they had they were really, really tough sclerocontact lens wearers. So we decided, and they were older patients, but we decided to improve the shape with CTAK and then basically do cataract surgery. And then, it sounds like Stephen's done, a fair number of PRKs. We're fairly early into our experience here, and the results have been so good that I think I've got one patient I did PRK in later on, but certainly is a possible scenario.
Mm-hmm.
Yeah, so I have done quite a bit of PRK after CTAK. Usually we'll make the patients wait about 6 months before doing it just to really get good stability, limited epithelial change at that point, and get a really good sense of their refraction. I will do it either sometimes topo guided to just get even more effect in certain cases, but these are cases where you wouldn't have the opportunity to do topo guided in these patients at all because it would just have to remove too much tissue, and now you're really just kind of refining and really not removing much tissue at all. I've done a handful of more, even what I would call refractive PRKs over it to a limited degree, which also have been very successful for patients who did have limited refractions and very good correction. I know there are a few cases that have been done now already with ICL after CTAK as well, which have been successful. And I've also just started having a few patients who needed cataract surgery with it, which is much easier through a clear inlay.
Very good.
And so when you said, Steve, that for limited, corrections, what do you consider, what refractive error would you consider limited?
So I don't even base it as much on refractive errors. I base it on sort of how much tissue is
Yeah.
going to get removed from the laser. So clearly based off partially just how thick the cornea is and what's remaining. I don't love to remove more than about 40 microns of tissue from these patients in general. That's kind of a rough cutoff that I usually have for most of them. So if the refraction is going to call for really more than that, I use 6 millimeter zones for them, so I am working in a smaller area usually, but if it's calling for much more than that, I'm pretty hesitant to do it, to do much more. I do think it works decently well sometimes when you have the flattening that remains up top, which the CTAK isn't taking care of. And if they are really more hyperopic, you can sometimes get some effect by actually treating the periphery, getting some steepening there, and you can get a decent refractive effect that way.
Excellent. Well, thank you all so much. Phenomenal job on your presentation. It's so amazing to have 250 cases represented on the screen here.
Bernie, can I actually interject one thing though, just for the people who do the CTAK in 2 places? I was just thinking this before. I really recommend dissecting the channels immediately after you do the laser. So if you're going to do your CTAK a week later, dissect the channel on the spot, and then it's very easy to open it back up when you get to the OR. If you don't do that, you're going to be kind of searching around for where things are. It's a lot harder to dissect. So I meant to say that a long time ago, but I just wanted to get that in. If you are really separating them out by days or weeks, it's totally fine. Just dissect the channel right where you make the laser cut.
Perfect. Excellent
Sorry.
pearl. Excellent pearl to end with. So very good. Appreciate your time. I know we've gone a little bit over, but well worth it. Thank you all very much for sharing your expertise. And for all of you watching, have a great rest of your evening. Thank you.
Thank you.
Thank